So good afternoon. My name is Jangho Yoon. I'm a health policy faculty member in the School of Social and Behavioral Health Sciences, College of Public Health and Human Sciences. This research, I'm going to talk about the findings from a specific analysis in a project that my colleague is in Health Management and Policy Program, and I have been collaborating over past 60 years. And my title is Providing Health Insurance under Obamacare, Improve Screening and Treatment of Maternal Depression Among Low-Income Women. Pretty much give you a take-home message. So if you want, you can leave with this take-home message, or just hope you stay here to kind of take a look at what's in there. Okay. So first of all, I'd like to acknowledge my contributors, Dr. Maury Harvey and Jeff Luck, and this study was funded by CDC. So depressive disorders are highly prevalent and chronic persistent conditions. The annual prevalence increased from 6.7% in early 2000 and up to 8.7% more recently. Depression also incurs significant economic cost. From 2005 to 2014, depression-related cost estimates increased from $103 billion to $238 billion measured in 2014 dollars. Depression is the leading cause of mortality and morbidity, especially among women. The risk of depression is greater for women than men by over 50%, as shown in this figure. And at least 1 in 10 peripartum women are affected by depression, or slightly more women affected during the postpartum period. Depression disproportionately affects low-income mothers and their infants and young children. And untreated maternal depression can lead to many harms for both mothers and their infants, such as low birth weight and preterm birth, elevated risk of physical, mental, cognitive, social-emotional, and behavioral problems over the longer term, more severe and chronic depressive episodes in new mothers that may require costly hospital emergency department visits or inpatient admissions. So untreated depression among low-income mothers can create 2 generations of suffering eventually. Unfortunately, only about 4% of US adults are screened for depression annually. Even when depression is detected, access to treatment remains significantly limited for low-income mothers. For example, a recent study found that approximately 35% of women with severe depression and less than 20% of women with moderate depression actually visited the mental health care providers in past year. There are several causes for this low treatment rates, including a lack of health insurance coverage for mental health services, lack of trained mental health care providers, stigma, and distrust of mental health providers. In this study, we examined a policy measure that can improve the detection and treatment of depression by addressing the lack of health insurance coverage. Now, let me give you a brief introduction to Medicaid program. Medicaid is a social health insurance program in the United States for low-income families, administered by states, government, and jointly funded by state and federal government. It is primary funding source for perinatal and maternal services for low-income women in the United States. About 40% of pregnant women are covered by Medicaid, and Medicaid programs nationwide finance nearly half of all births in the United States. By federal law, all states must cover pregnant women with family income at or below 138% of federal poverty level through pregnancy-only Medicaid. although many states opt to go beyond that, like 185% FPL in Oregon. Unfortunately, this pregnancy-only Medicaid covers new mothers only up to 60 days postpartum. This is problematic because this Medicaid policy may disrupt the continuity of Medicaid coverage for many low-income women. In 2014, the Patient Protection and Affordable Care Act, also known as Obamacare, gave states option to extend their Medicaid program to cover low-income individuals with family income at or below 138% FPL, regardless of pregnancy status. So US states that opted the Medicaid expansion under ACA effectively extended coverage for many low-income mothers beyond the pregnancy and 2-month immediate postpartum period. To date, 37 states and the District of Columbia have expanded their Medicaid program, including the state of Oregon. Importantly, the expansion states must provide maternity care and preventive care, including depression screening, free of charge to the patient, under the definition of alternative benefit plan. States also must provide comprehensive mental health and substance abuse benefit. Therefore, the ACA Medicaid expansion presents a unique opportunity and natural experiment to improve the detection and treatment of depression during the pregnancy and postpartum period among low-income women. So in this study, we examined the impact of ACA Medicaid expansion in Oregon on the screening, diagnosis, and treatment of peripartum depression among low-income women of reproductive age. A little bit about the kind of academic thing. So we linked data from multiple data sources, including Oregon birth certificate data and Oregon Medicaid Management Information System for Medicaid enrollment, medical claims, and pharmacy claims data, and hospital discharge data. Oregon birth certificate data used for this study included all mothers in Oregon who gave birth, live birth between January 2011 and December 2016. Using this data, we created an analytic data set that included one pre-expansion observation and also one post-expansion observation for each of 8,460 unique women. So the study population included women who had childbirth in both before and after the Medicaid expansion on January 1st, 2014. So our policy group, so intervention group, consists of those women who benefited from the Medicaid expansion in Oregon. So those who were on pregnancy-only Medicaid or uninsured before Medicaid expansion, but fully insured, covered by Medicaid after the expansion. The control group included those women who were pregnancy-only Medicaid or who were uninsured at the time of birth in both pre and post-expansion period. So using this analytic data set, we obtained pre-post change in depression outcomes for the policy group in comparison to the control group. So this resembles typical pre-test, post-test treatment control group design. And we examined 20 different binary depression outcomes. Regarding depression screening, outcomes included indicators of depression screening separately for the first trimester, second, third trimester of pregnancy, and 2-month and 6-month postpartum period. As such, we examined 5 diagnosis outcomes. And in terms of treatment, we considered psychotherapy and pharmacotherapy separately, of course, for depression. And we used mathematical and statistical modeling technique called difference in differences, controlling for observed and unobserved heterogeneity of individual in the policy and control group. So in plain English, this means that our method likely yield the causal effect of Medicaid expansion on women targeted and treated, so actually affected by the Oregon Medicaid expansion under ACA. So findings, this figure on the left first, okay. It shows average probability of depression screening before and after Medicaid expansion, separately for the policy and control group. If you look at the orange bars are for the policy group, and the gray bars there are for the control group. And the diagonal strip pattern, you see diagonal strip pattern there for before Medicaid expansion, and solid fill bars are for post-expansion. So first, on the left figure, for the control group shown by the gray bars, you see the probability of depression screening always slightly increased post-expansion. So, for example, I don't see it very well too, but it just slightly, if you look at the gray bars, it's slightly increased. In comparison, the orange bars for the policy group of people, women who are affected by the policy, so got Medicaid coverage after Medicaid expansion, the probability of depression screening increased during the first and second trimester, and decreased in the third trimester, and then substantially increased in both 2-month and 6-month postpartum period. Now look at the figure on your right. The probability of receiving diagnosis of depression almost always dropped in the control group slightly. However, it increased somewhat significantly during the first trimester for the policy group. Okay. Now, overall, the probability of receiving psychotherapy on your left, psychotherapy for depression increased for both policy and control groups following the expansion. However, we can see huge increase during the postpartum period in the policy group compared to control group. The probability of pharmacotherapy here increased substantially for the policy group. However, there were slight decreases for the control group. So this shows the overall kind of pattern of increase in the screening, diagnosis, and treatment of depression, slightly greater increase for policy group than control group. This slide shows the main result of depression screening. And the numbers are here is so-called marginal effect, which captures the magnitude of the effect of Medicaid expansion, and it wrapped around by the 95% competency interval for statistical significance. First of all, Medicaid expansion was associated with 1.55 percentage points increase in the probability of depression screening during the first trimester of pregnancy, although it is significant at the 90% level. If we move to the right, the impact of Medicaid expansion on depression screening are positive and significant postpartum. And as expected, the magnitude of effect becomes larger over time during the postpartum period. So to gauge the magnitude of this identified effect, for 6-month postpartum period, the 4.85 percentage point increase, it represents 31% increase from the pre-expansion average for the policy group. In terms of diagnosis of depression, we can see that here for first trimester, Medicaid expansion was associated with 2.04 percentage point increase in the probability, meaning that this actually represents almost twofold increase in the pre-expansion average for the policy group. So the magnitude is really significant for the first trimester depression diagnosis. Now, treatment, so first psychotherapy, we can see that 2-month and 6-month postpartum probability on the right-hand side were significantly associated with the Medicaid expansion by 3.5 and 7.1 percentage point increases respectively. These increases represent roughly, again, twofold increases in the pre-expansion probability for the policy group. So again, we find significant, substantial policy impact of Medicaid expansion on psychotherapy. In terms of pharmacotherapy, we find almost always significant and positive result. And this represents about 30% increase from pre-ACA baseline for policy group. So, what's the conclusion? So, taken together, findings that I just presented shows that Medicaid expansion under ACA led to significant improvement in detection and treatment of depression among low-income peripartum women of reproductive age in Oregon. There are some important discussion points here. So, examining effect on non-peripartum women and men at risk is beyond the scope of our analysis, and we don't have data on that. However, we don't expect that the beneficial effect of Medicaid expansion we just found, we don't expect that this beneficial effect differ for different low-income subpopulation, and also even for residents in other states. Because under the federal policy, what state have to do under Medicaid expansion literally homogeneous across the state and across different subpopulation. Our findings might imply that Medicaid expansion eventually could lead to cost savings for Medicaid program through early detection and adequate treatment, which can prevent an initial symptom from developing into more serious conditions. Such cost savings may not be trivial and can save a lot of taxpayers' money. And we also need to factor in potential spillover effect of Medicaid expansion. For example, early detection and treatment can also lead to prevention of severe co-occurring disorders, cost savings to welfare and criminal justice system, and increased productivity for employers. Now, what's the next? As you can see, to date, 14 states, mostly southern states here in yellow, have not adopted the Medicaid expansion yet. Okay. Based on our findings, those states are losing the opportunity the Medicaid expansion may offer to improve depression treatment for peripartum women. Hopefully, those states start soon to adopt the lessons from other expansion states like Oregon to improve maternal well-being, mental well-being, and of the low-income women and their family. Okay, this is all I have.